Hey everyone, we're going to go ahead and resume our agenda for the day. So if you don't mind just taking your seats, we will have plenty of networking time later. So if you're making new friends and new contacts, don't worry, we'll circle back on that. But we do have a really amazing panel that I'm pleased to introduce. Oftentimes, tribal governments, can be relatively small, and some of their grant writing capacities are, either limited or in some capacity different from obviously like state or county governments. And it can be a little, intimidating because counterposed from that tribal government is the entire federal bureaucracy, right? And so we're trying to shine a light on some opportunities that exist within the federal government for tribes to be able to take advantage of funding resources and other technical assistance resources to tackle environmental health challenges and provide solutions in agencies that, are kind of are top of mind for environmental health, and then some other agencies that we don't necessarily think of in first light. So I'm going to introduce my panel members. First, from the Oklahoma Poison Control Center, we have Christy Adelin. Christy is the managing director of the Oklahoma Poison Center. She joined the Poison Center in 2012 and became a diplomate of the American Board of Applied Toxicology in November 2018. And she has been with the Oklahoma Poison Center full-time for 11 years now, and she gets to do a job every day that she truly loves with people that make the job enjoyable, something that I am also pleased to be able to say. Next, we have Henry Manager, currently the senior epidemiologist for the environmental health epidemiology section at the Kansas Department of Health and Environment. He provides epidemiological support to many programs, including the Kansas Environmental Public Health Tracking Program, the Blood-Lead Poisoning Surveillance Program, and the Environmental Health Capacity Program. He has more than 40 years of experience in implementing local, state, and international public health interventions. Next, we have Captain Mehran Massoudi, who was appointed with the Regional Health Administrator for the Office of Assistant Secretary for Health at HHS Region 6, which covers the states of Arkansas, Louisiana, my home, New Mexico, Oklahoma, Texas, as well as the 68 federally recognized tribes in that area. Prior to joining OASH, Dr. Massoudi served as the branch chief for Applied Research and Translation branch and the director of the Prevention Research Centers program at CDC. Over the course of his professional career, he has served as the CDC Epidemic Intelligence Service Officer, and in 1994, the science advisor to the smallpox team at CDC's National Immunization Program, the CDC SARS surveillance team lead, and as an associate director for science at CDC. From 2005 to 2007, he oversaw the development of the Afghan Public Health Institute within the Afghanistan Ministry of Public Health. We're also joined today by Michelle Tinnen. Michelle is the Senior Native American Program Specialist for the Office of Native American Programs at the U.S. Department of Housing and Urban Development. She served as Program Environmental Specialist for Southern Plains Office prior to accepting the position this year to work directly for the Deputy Assistant Secretary and the Associate Deputy Assistant Secretary. She has worked for HUD 32 years, and 26 of those years have been working with tribes and tribally designated housing entities. And I'm also joined by Commander David Bales, who has been with the Indian Health Service for 14 years and is currently the Injury Prevention Specialist for the Oklahoma Area Indian Health Service. His education background includes a BS in Environmental Health from East Central University in Ada, Oklahoma, the IHS Injury Prevention Fellowship and MPH from the University of Oklahoma. And Mr. Bales is registered environmental health specialist and a certified safety professional. And joining us virtually is Danielle O'Neill, who is a life scientist with the EPA Region 6 Safe Drinking Water section and has been with the agency for 2.5 years. She focuses on technical assistance for the Tribe Direct Implementation Program, helping to uphold the National Primary Drinking Water Regulations and Safe Drinking Water Act. Currently, she is the point of contact for environmental justice, climate change, and climate adaptation for her section. And that's a lot of talking, and I'm done with it now. So welcome to our panel.
Okay, so I'm Christy Edlin, Managing Director for the Poison Center. Let's see if this works. Do I just need to tell you guys? Okay. Oh, okay. Yes. All right. There we go. All right. So thank you so much for allowing me to be a part of this panel and to explain to you guys who we are at the Poison Center and how we can help you out. I was going to keep this short and sweet to like 10 minutes or so, but we have longer for the panel, right? So I promise to keep it less than 3 hours. Okay. All right. So currently there are 55 poison centers across the US, and they all have their service regions. So for me personally, I work for the Oklahoma Poison Center. Our service region is Oklahoma. And I think you probably think, well, duh, it makes sense, right? But there are poison centers that are very large poison centers, and they will manage much larger territories. So some states that don't necessarily have poison centers, that say Rocky Mountain Poison Center, who is a huge poison center out in Colorado, manages several different states. And then we'll see here just in just a second, there are some states that actually have multiple poison centers. But across the US, we have 55 poison centers. We are there 24 hours a day, 7 days a week. I always say we're kind of like your 911 system, your emergency system. We're always there 365 days of the year. And if you don't remember anything from what I say today, it's that 1-800 number. So 1-800-222-1222. No matter where you are, how things are routed, which we'll talk about here in a second. If you call that number, you will get poison information and support. We may route you to your local poison center, again, depending on how your call is routed. But just remember that 1-800 number. So we serve a dual role as both part of public health infrastructure and as a service to offering individual patient care assessment. So we work with individuals like all of you in this room, but of course, we're probably most known for that place that you call when your kid gets into stuff or when you accidentally take your medication twice and those types of things as well. So just to give you a little bit of an idea of our Oklahoma Poison Center, we have 11, we call them C-SPIs, so certified specialists in poison information. For our poison center specifically, we're talking all of our C-SPIs are pharmacists, and we have one nurse. So these are not, I always kid, it's not just random people that we bring in off the street and say, oh, you sound great on the phone, we'll set you up in the poison center. These are actually pharmacists and nurses that are answering these calls and that are specifically trained. So once someone comes on board with us at the Poison Center, it's about a 2-year process to actually get them trained in handling the calls that they're going to be expected to take. And once they've handled 2,000 human exposure cases, they sit for what we call a C-SPI exam. And so, of course, a little bit of a grueling exam that they have to sit for, and they have to retake that every 7 years. So again, not just a random person that you're just calling and we're just Googling information, right? So these are actually people that are specifically trained in poisoning information and poisoning management. We have 13 information providers. So these are pharmacy students. So here in Oklahoma, we are run through the College of Pharmacy. We actually train pharmacy students to help us triage calls. So they have a certain subset of calls that they can take themselves. But for the most part, they're taking down information for us and passing it along to our specialists. And they work specifically in those high call volume times. So evenings, weekends, when our call volume really ramps up. One admin assistant, which I'm actually looking to hire. If you know anybody, send their information my way. One public educator, one clinical toxicologist. So our managing director actually just retired last month. So I am 26 days into this gig. It's going okay so far. And so I'm our clinical toxicologist. I'm a pharmacist by trade. And then we have 2 medical toxicologists, Dr. William Banner and Dr. Claire Epperson as well. You may hear them speak at events as well. So just to note, because I do recognize that there are not only Oklahomans in the room, we also have the Texas Poison Center Network. So this is an example of a very large state, obviously. And so they actually have 6 poison centers scattered throughout their state. You can kind of see their service areas. But as you can imagine, things overlap. In cell phones, people may keep that same cell phone number in travel. So they are actually part of one big network. And so any poison center that you call down in Texas, more than happy to help you, of course, and then they can get that information to the appropriate poison center if need be. Kansas, I did not give Kansas a shout out. I'm sorry, I should have, but they're pretty straightforward, kind of like us in that they service Kansas. That's their service area. So what do we deal with? So of course, like I said, this is always going to be poison control's bread and butter. We're always going to get those calls of my kid got into XYZ around the home. We also deal with kids getting into medications. But since we are staffed by pharmacists and nurses, we are ideally trained in helping in those drug information calls. Don't know if you've been to your local Walgreens, Walmart, CVS lately, but the line is a mile long. So getting to actually talk with a pharmacist may be a little rare when you go to pick up your prescription. So asking those questions about drug interactions, I'm having this weird adverse effect. Is that from my medication? Those types of questions we can answer as well. This time of year, snake bites, I would say, are our bread and butter. I think that that's something that a lot of people don't recognize is that we're not only there for the public, about 25% of our calls actually come from healthcare providers. So EMTs on scene with a patient, physicians and nurses, PAs, whoever it may be that are working in emergency departments that are actually managing these patients. So this time of year, snake bites. We're dealing, I would say on average, we get anywhere from 3 to 4 snake bite consults a day. Sometimes that's at the lower end of things, but that is definitely one of the things that providers will reach out for us for management with these snake bite patients. Intentional abuse type scenarios, intentional suspected self-harm scenarios, plants, mushrooms, berries. I always tease that if you don't know where to call the poison center, because if it's not us, we can at least tell you where you need to call, which the state epidemiologist knows very well. We get our fair share of rabies calls. And of course, that's a little bit out of our jurisdiction. So we pass those off to the state epidemiologist. So main goals here, reduce morbidity and mortality associated with poisonings. Poisonings can include exposures to things like medications, supplements, illicit drugs, of course, household products, environmental toxins, plants, venomous insects, and animals. So again, we're available 24 hours a day. We do have TDD and TTY for hearing impaired. We also have the ability to have 150 languages, so translated. So to get a translator on the line for us for 150 different languages. It's free to call us for both the public and for healthcare providers. In 2022 for Oklahoma, we received just under 35,000 poison-related calls. These are poison-related calls. These aren't just drug. This doesn't include our drug information calls as well. But I think it's also interesting to note we placed 33,000 follow-up calls. So not only are we getting those calls from home, we're calling mom back and saying, hey, how's little Johnny doing? Is he getting sleepy like we would expect? Or is he running around and playing normally? So we make those follow-up calls, not only to home, but also probably more so with our healthcare facilities. So again, those snake bite patients as an example, we're not just going to say, oh yeah, give them anti-venom and good luck. Call us if you have any other questions. We're actually going to follow up with them and make sure that the patient's being treated appropriately and make sure the provider doesn't have any further questions for us. So overall goal is to save healthcare dollars. So poison centers help prevent unnecessary health-related costs. So as you can imagine, I know I have a 3-year-old at home, personally getting into just about everything. And it's good to know that there's somebody that is out there that I can call. And I'm not having to just rush to the emergency department every time my child gets into something. So we're saving healthcare dollars by, our goal is to try to keep people at home. Last we looked in 2022, we were actually able to manage well over 95% of our home calls at home. So those are all people that we're keeping out of the emergency department. We also co-manage, like I mentioned, with healthcare providers. We are going to follow that patient through what we call 2 determined outcome until they're clinically stable, essentially, to make sure that there's no further recommendations that need to be made. I kind of see us as a consult service. So if you go into the emergency department with a broken bone, a lot of times they're going to consult ortho. Pregnant patient, they're going to consult OB. For a tox patient, chemical related exposures, anything like that, they're going to consult the poison center. And again, we're going to follow those patients through until they're clinically and medically stable. Surveillance. So as I mentioned, there's 55 poison centers. Every 7 minutes for our poison center in particular, our data is uploaded to a national database. Every exposure that comes into us, we create a medical record, just as though that person were to go to their doctor or to the emergency department. We create a medical record for that case. And every 7 minutes, those records are uploaded to a national database. This kind of makes us the first lines in identifying some of those outbreaks and exposures that may be occurring, because I guarantee you, if one of our specialists, Esther's on the phones right now, if she enters in a case of botulism or radiation or something like that into the system, someone from national is going to be calling me and saying, hey, what's going on in Oklahoma? Is this of public health significance? And so it's our job to figure out, yes, this is something that needs to be put on the radar. We need to get all people hands on deck to come and help and manage this type of exposure. So we share information with FDA, DEA, ATSDR, CDC. So all of the above, we basically play friendly with our data. And again, we are the first lines in trying to identify some of those outbreaks that may happen. So we also do public and professional education. So every month on average, we have anywhere from 3 to 6 rotators that are coming through our poison center. So they are learning clinical toxicology. Most curriculums, most residencies now require toxicology as part of the education process. And so we do a lot of provider education, but then public education. So this is our educator, Laura, you may have seen her out at some of our events, and then some of our poison information providers out working events to provide public education as well. Drug and product safety research. So we kind of tease, we have a wall of shame in the poison center. So anytime we get wind that there's something out there on the market that probably shouldn't be available to the general public, we not only identify the appropriate people that need to be told of this, but we also try to make it our goal to get our hands on one, just to keep on as a board of shame of things that probably shouldn't have come to market. So I just want to dispel this thought today that poison centers are just for kids. That's just the place that I call when my kid gets into stuff. We're really for everyone. Poisonings happen to anyone and everyone. So you can kind of see the age demographics there and the most common calls that we handle for the different age demographics. But it doesn't have to be your kiddo that's getting into something to be able to call us. So you may be asking, well, why are you on this panel? And what does this even have to do with environmental health? Well, we're going to talk about that. So crowd control, as you can imagine, for the general public, anytime we have any type of outbreak, exposures to things, people will have a lot of fear. And so depending on what it is, a lot of times the poison center is the first call that people are going to make. And so we can really deal very well with what we call the worried well. So people that are genuinely concerned, and rightfully so, but being able to triage those calls based on what's going on, based on the information that we're getting from you all that are out dealing with the environmental part of this. So I always say we have clinical toxicologists. So we specialize in what's going to happen to the human body and how do we treat it. You guys are helping us to try to determine what area of the population should we be saying, yes, you need to seek medical help now, versus no, you are in what we call the safe zone, and you can remain at home. And what message should we be getting out there to the public? So that, if again, a key take home for today, just keeping the Poison Center in the loop whenever we are experiencing these types of events, these types of exposures, because most people are going to be contacting the Poison Center. And so a lot of times we are the first voice of an authoritative type person that they are actually getting information from. So keeping us up to date on what's going on really kind of, it benefits everyone. So some examples, Fukushima, what happened in 2011. So, of course, because of the tsunami, we had this radiation event. So long story short, I'm sure you guys know some of the ins and outs of that. It was radiologic cesium that was basically people were being exposed to potentially. But here in the United States, we had people that were really hysterical in trying to obtain potassium iodide. And we would get calls on, how do I obtain it? What dose do I take? What do I do if I can't find it? Am I going to die? Those types of things. And so just educating them on, number one, we are located an ocean away, so you're probably okay. And then number two, potassium iodide is only good for one type of radiation, and that's radioactive iodide. And so in this situation, even if they found it, it's not going to be of tremendous benefit in that situation. So just educating the public and just providing them with a little bit of resources just to calm their fears and to settle that. Again, poison centers are great at that. Mercury spills. So I don't know, some in the room may have actually helped us with some of these. People call us all the time. I broke a thermometer, which nowadays most of them are alcohol, but I have an old school type thermometer that broke in my home. How do I need to go about cleanup? And that obviously very small mercury spill, and we can walk them through how those need to be dealt with. Large spills though, that's where we need you guys, a lot of you guys here in the room, to help in going out, making those assessments. What needs to be done? We are good for what clinical outcomes are we going to see for that family that's been living in that home now for 6 months with this mercury that's spilled into the carpet, and how are we going to treat those? So a lot of times being able to triage those patients as well and provide management, obtaining antidotes if needed. If you're not aware, antidotes, few and far between. They're very expensive to make and manufacture. They're very expensive to keep on hospital shelves. So a lot of times very difficult to find them. Again, that's where the Poison Center can be greatly utilized. Of course, we're all familiar with what just happened in Ohio. So Ohio got inundated, their poison centers, with, I've got XYZ symptoms. Do I need to go to the emergency department? Again, just keeping your poison centers up to date on what's going on there on the scene, at the scene, and then providing that information to us so that we can make those clinical judgments of, yes, you need to go to the emergency department. No, you can safely stay at home. And once they make it to the emergency department, what happens then? So we're working with those healthcare providers in that situation as well. Deepwater Horizon, I know a Louisiana Poison Center helped tremendously with this as well, whenever we had the oil spill down on the Gulf Coast. This is one, I put this in here just because it's an example of where we could have been utilized better. So we had this warehouse fire here in the city where we had a bunch of hand sanitizer that was burned. And yeah, my clinical gut, seeing hand sanitizer calls, probably about 3 a day for the last 11 years, tells me we're probably burning alcohol. But I didn't know that. We just came out of a pandemic where we had tainted hand sanitizer with methanol. And so trying to obtain information about what specifically was burning, you've also got to consider the plastics potentially that are being burned at this facility. We were stonewalled. And so we had people calling us wanting to know what they should do. Most of the time they were asymptomatic. And so we were able to triage based off of symptoms. But every authority that we called to try to get information on what specifically was being burned, we were basically shut down and told, we can't provide you with that information. So I just put that in here as just a learning example of, again, how the Poison Center can help in managing these types of cases. And don't forget the number 1-800-222-1222. So I think the plan is for me to turn it over and then we'll do questions at the end. Okay.
Thank you, Christy. And I'd like to ask for another round of applause for Christy because they are very, very important players in the system and the public health system. And I think my name is Henry Ménager, and I am currently working with the Kansas Environmental Public Health Tracking Program and many other environmental health programs. And I want to thank the people who invited me here and also recognize the host and the tribal lands that I'm in right now. Now, we want to talk about environmental health and resources, but I want to repeat what several speakers have said before me. When public health these days is about environmental health, and I think Mr. Meek made a point about that. Environmental health allow you to effectively connect the dots. And if there is anything that we've learned from COVID is that public health should make an effort to move ahead of the curve, because we've been behind the curve for a long time. And partners like the Poison Control Center, the syndromic surveillance system that we have in place, those are tools that allow us to stay ahead of the curve, because we need to know what's going on in the populations so we can have appropriate interventions. And one thing is, if you have a case of measles in the emergency department, for example, it's easier to deal with it right then and there than to have this case in the public and contaminating other people. So how do you know that? And I think the syndromic surveillance system allows us to do that. And this is the same thing also for the Poison Control Center. We've been putting together data share agreement with the Poison Control Center, which is in Kansas City. And it's a very invaluable partnership. We have almost daily communications, and when those alerts that Christy was talking about come in, and that's really helpful, because that allows us to take action immediately. So recently we've had a case of radioactive material that was handled by a child, and that created a lot of problems, a lot of concern. But fortunately, we learned about it early enough so we could control the situation. As an introduction, I think I can't really emphasize enough the role of environmental health these days in public health. And so I just wanted to briefly introduce with a few resources that might be of interest to Indigenous people who are living in Kansas, and also the members of the tribes that are located within the state of Kansas. If there is any members listening right now, and also share with the public, the audience here, how the situation is handled in Kansas. So my resources that I'd like to share can be summarized in 3 categories: data, program and services, and human resources. So this list that I'm about to share here on the slides, they have a lot of links that I don't know if I'm going to be able to, click on them or demo them, but I have a few notes here, and I'd be more than happy to entertain questions about them. So this list is not exhaustive, and it's just a collection of items that might be leveraged to improve health status, and specifically improve data collection in relation to indigenous people living in Kansas. But let me start to say that, the Kansas population, the proportion of American Indian and Alaska Natives who are part of the population in Kansas is only 0.8%. So most of the tools and methodologies that we use to collect data are most of the time are not able to provide the measures and the statistics that we need to assess the health of the population. So and as somebody mentioned here, it's about 75% of the American Indian population who live in cities, and they are living outside of the tribal lands. So we cannot really share this data most of the time because of privacy concern, because of very small numbers. And also the fact that those rates are becoming unstable if there are small numbers. So you can't really compare them with what's happening with the general population. Nevertheless, what we do is to really, use estimates and have an idea of how the situations are at the tribal level in Kansas. And the other challenge that we also have is the data collection on race and ethnicity. And I think 25 years ago, there's a saying that you were born American Indian, but you die white. Because the way the data was collected, somebody look at the deceased and say, hey, you look white to me. So check the white box. So the statistics in that case are biased, to say the least. But I think we've been making a lot of progress. And this progress, I should say, is due to the fact that we started to engage with the tribes. And as somebody mentioned earlier, I think it was Shay, who said that, who owns this data? I think the data, if you ask me, should belong to the indigenous people. But just saying that is one thing, but giving them the opportunity to use this data to inform public health, and also to assess the situations and how to use this data effectively. That's another issue. So we not only need to share this data with the population, to the tribes, but we also need to put resources at their disposal so they can use this data accordingly, appropriately. In that same vein, I would say, when I was coming here and really insisted to bring somebody who is really interacting with the community. And I know Jerome is here. Jerome came with me, and I think gathering the data is one thing. Being able to interact with the population that owns the data and making it inform public health is really important. So the community outreach, talking about equity and all those issues are really important as far as environmental health is concerned. Just going to go over a few of those data systems that we have in place in Kansas. There are a lot of them, but some of you are familiar with them, others, so that's why I'm going to briefly talk about what they are. The Kansas Behavioral Risk Factor Surveillance System is where we get information about, obesity, smoking rate, mental health. And this is really important as far as environmental health is concerned, because the only way to know about those things, behaviors, is to ask the population. So now the Behavioral Risk Factor Survey Surveillance System in Kansas interviews over the phone between 10,000, 20,000 people a year. So you can imagine that since this is a sample, the American Indian population is underrepresented. So most of the time you don't have statistics for the American Indian and Alaska Natives in this survey. This is probably the same thing for the use YRBS, which is the I'm blinking on that, but Youth Behavioral Survey, and it is conducted every other year. And in this survey, you can have some statistics for the American Indian and Alaska Natives. However, you have to pull the data on several years, and that removes, the trend that you may need to look for in this data. Then we have the annual vital statistics that talks about, birth and death. But for them, for the vital statistics, what we're looking for as far as environmental health is concerned, we're looking for birth rates, low birth rates specifically, because that's one of the major consequences of environmental offenses, fertility rate, mortality rate, and specifically infant mortality rate, which is a very sensitive indicator. Then we have the Kansas Health Matters. That has a lot of information here, and try to provide a combination of health outcome and also environmental health indicators. But again, this is not sufficient because it doesn't provide or information about what's going on in the indigenous people population. Kansas Cancer Registry, this is the same issue and that's where the importance of having a data use agreement, because we can have very specific studies and data collection that may provide information about what's going on as far as cancer is concerned. And a lot of time we think about environmental health, the first thing that pops into the head is cancer. However, a lot of the cancers that we see in general population and in also in American Indian Alaska Natives are due to behaviors. So that gives you an indication of in this cancer registry what you can look for and try to address it at the population level. The next data set is the Kansas Environmental Public Health Data Explorer. I don't know if anybody can click on that link. That's going to be the Kansas Environmental Health Explorer. Data Explorer. Yeah, I don't know if you can see this. It's a little bit faint, but what I would say is that this is a repository where we have both health outcome and environmental factors. So if the first drop down, if anybody can click on the first drop down here, right? Those are a number of factors that we look at, like air quality, asthma, birth defects, cancer, carbon monoxide poisoning, childhood cancer, childhood blood lead poisoning, COPD, drinking water, heart disease, heat-related illness, and so on and so forth. So those data are shared nationally, and we're part of the national network that put side by side those health outcome and environmental factors, so we can understand what's the relationship between environment and health. So if you can click on the county profile on the top, on the right side. Nope. No, up. Yes. So for each of, for each of those counties, we have developed profiles. And if you can, somebody can click on, let's say, Brown, which is the second to the right. Brown, I've lost Mike. Okay, and then view county profile. Yeah, okay. So this is kind of a summary of, kind of a 30,000 feet view of what's going on and trying to put together environmental factors in health outcome together. And this data dates from 2019, and we're in the process of updating it to 2020. So the idea is to give each one of those communities some kind of idea how environmental factors can impact their health. So thank you. If you can come back to the slide, please. Yeah, so we just saw the county profiles, and I think that's one way that the tribes can, have an idea of what's going on in their communities. And again, the tribes in the Northeast Kansas, we have 4 of them. And so those are the Iowa tribes, and they are halfway between Nebraska and Kansas. We have Prairie Band, Potawatomi, and Kickapoo and Sac and Fox. So those tribes are, their size is about, people who live on those tribal lands to about 5,000 to about a few hundreds. So you can understand it's really difficult to, tease out those statistics because of the small numbers. Then I wanted to just mention the programs, a few programs that are, working with the tribes to address those. We have the disease and injury prevention, and most of them are intentional and unintentional injuries. diabetes program, the arthritis program, the cardiovascular disease and stroke prevention programs, and injury and violence program, as I mentioned earlier. So all of those programs, they can provide assistance to the tribes as they are dealing with these problems. On the environment side, one thing in Kansas, the health department and the environment department are under the same administrative authorities. So there is a lot of communication between both environment and health. So we really appreciate the collaboration in this setting, and I think that facilitates things a lot. And what that allows us to do is to kind of having a One Health approach in a sense that things that happens in let's say in animals, we can look at this as a precursor or indication that may have impact human health. We have some other resources like Kansas Environmental Health Finder, Interest Finder. This is a interactive tool that helps the regulated community find information about environmental and health safety programs. The bulletins and environmental health handbooks, those are the succinct technical educational documents for the public and environmental matters. We have the wastewater option for smaller communities. Those are basically how-to guides for small communities to address wastewater. And also we have of course, the harmful algal bloom program that address, blue-green algae in public waters. And so that is also a very important program where the Poison Control Center is, providing valuable information, because people call the Poison Control Center, and the Poison Control Center will send us an alert telling us that they got a call, so we can get this information and document it further, so we can go on the lake and sample and see if we find toxin in the lake. Okay. So the green infrastructure, those are, programs that refer to systems that and practices that use or mimic natural processes to infiltrate, reuse, evaporate stormwater on site and in rain gardens. For example, those are examples of green infrastructure. There's a program that we just started in KDHE that help deal with climate issues and also I'd like to mention those phone numbers that people can call. We got the epidemiology hotline that they can call for any reportable disease or any condition that appear to be unusual, and the providers are encouraged to do that. We also have the Kansas Spill and Hazard reporting line that is manned 24/7. I have a list of numbers on this website. Those are numbers of the Poison Control Center, of course, and also we have the county sanitarians. Those are really good resources. They help, inform the population in those counties on what is available to them and help them in their projects. So I encourage people to use them as much as possible. And I know that this is group of people that tend to disappear because of funding sometimes. But so far, we've been able to maintain a certain number of sanitarians in the state. And I want to mention the Kansas Native American Affairs Office. This is an office that is serve as a liaison between the governor's office and the Native American communities. And I think that people always need to use that as much as possible. And I encourage them to get in contact with them because they do the coordination as far as the communication and implementing programs between the governor's office and the other state agencies. So without going into all those links, and I had a presentation that could last 2 hours. So I'm just giving you just an overview of the many things that is going on right now, that are going on in Kansas. And I think environmental health is the way to go, and we need to provide more resources to environmental health. And we also need to make sure that we work closely with the communities, and it's not because they are very small, because they don't appear in our data, that's a reason just to ignore them. I think this is absolutely crucial, because what's happening sometimes in small communities may have very huge impact in the general population as a whole. And it doesn't make sense to have small communities to bear all the burden of health conditions and environmental conditions just because they are small. So on that, I'm handing my podium to the next speaker. Thank you very much.
Hey, good morning. So I'm Mehran Masudi, and I'm the Regional Health Administrator for Region 6. And so I'll be here talking on behalf of myself, as well as the Acting Regional Health Administrator for Region 7, Captain Davids, who's based in Kansas, Missouri, Kansas City, Missouri. Let's see. Thank you for putting up the slides. Go up to the next one, please. Actually, I can change myself, right? Okay, great. So just a quick outline, who we are and what we do and regional activities, and quickly go through vision for the future. I wanted to just give you an outline of the Department of Health and Human Services and talk about in terms of when we hear about the operating divisions. Many of you know about CDC, SAMHSA, ATSDR, Food and Drug Administration, NIH, HRSA, and so on, Administration for Strategic Preparedness and Response, so on. And those are the operating divisions. To the left, where it says Office of the Secretary, that's where our office is. And here is where the breakdown is of the boxes. You can see where shows Office of the Assistant Secretary for Health. That's where we are. The 10 regional offices within the Office of the Secretary divisions, Office of Regional Health Operations. And again, as I said, OASH oversees the department's key public health offices and programs, a number of presidential and secretarial advisory committees, 10 regional health offices across the nation, the Office of the Surgeon General, and the U.S. Public Health Service Commission Corps. The map of the country in terms of the 10 regional offices, they're the same regional offices as FEMA, HUD, EPA, and so on. And so you can see Captain Davids, Kansas City. talking about our mission, providing regional coordination and support for departmental public health initiatives and to help accelerate implementation of public health policies. We do this through the lens of health disparities and health equity. We work to promote and advance public health and safety of our communities by connecting people, convening local partners, establishing networks, providing public policy recommendations, and focusing on the underserved and vulnerable populations. And next, I want to quickly talk about Office of the Climate Change and Health Equity, OCHE, which was put through by presidential executive order back in January 2021, Office of Climate Change and Health Equity in the Office of the Assistant Secretary for Health. I know we'll have a talk later, obviously by Paul and talking about climate change, but this is just sort of our role in terms of HHS's role in the office. Climate change poses current and increasing threats to human health. As climate continues to warm, again, being outside is something that we can definitely feel. Risk to human health will grow, exacerbating existing health threats and creating new public health challenges. So the department is committed to taking actions across the whole department to protect the health and well-being of all people, especially those most vulnerable. Briefly about the Office of Climate Change and Health Equity is set to address the impact of climate change on health of the American people. The Assistant Secretary for Health, Admiral Rachel Levine, wants to create an environment where every person is safe and healthy. And that's why this office was created, to address this growing issue. So 3 main goals of the office: protecting the health of all people in the U.S. from the impacts of climate change, especially those most vulnerable; enhancing the sustainability of climate resilience of the U.S.'s health systems; and lastly, addressing underlying health disparities by identifying, promoting ways in which actions to address climate change can also improve social determinants of health. I wanted to briefly talk about 2 particular OCHE resources. One is the Climate and Health Outlook. This is it here. And this is sort of this is issued sort of like every other month or so. And this is an effort, Climate and Health Outlook is an effort to inform health professionals and public on how our health may be affected in the coming months by climate events and provide resources to take proactive action. So again, based on the fact that this is the July edition, so what you can see is that it actually has what you can do where you are in the country. So this is for the entire country, so it's not about region. And so given the fact that we're in the season where excessive heat, hurricanes, and so on, but it actually links to CDC websites, resources, FEMA, HUD, EPA, and where people can go for and what diseases one might be expecting depending on where the effects are. So again, it links those climate and health, and it lets people know what they can do in a more proactive fashion. Another resource is the Resource Hub, and that's designed to help health sector understand what resources, tools, and informational materials are available to accelerate the important work of emission reduction and climate resilience. And this hub, each of these boxes are hyperlinked in the website, so the links are there. You can get information on former webinars that have been done looking at that. Again, looking at climate hazards, especially on vulnerable populations, and leveraging IRA resources as well. I wanted to just do quickly looking at some of the health effects within our regions, doing a retrospective on 3 of these topics: heat, drought, and wildfire. And so if you just look, it's not rocket science, but you look at where was the heat abnormally high in 2022, Unfortunately, we can probably change that to 2023 as well, but we're just looking at 2022. This map depicts the number of summer days in 2022, April 1st to September 30th, when country's maximum temperature exceeded its 95th percentile, thus indicating an abnormally hot day. So again, looking at much of the southern Great Plains, which covers most of the states in our region, as well as those in Region 7, where they experienced more than a month's worth of hot temperatures. And this is a pattern that is expected to be seen next year as well. This is something that, again, we're looking at for all of the regions, and this is heat-related illness worse in 2022 compared to the last 4 years. Looking at CDC's National Syndromic Surveillance System, and looking at this graphic, basically was looking at comparing rates of heat-related illness per 100,000 emergency department visits from April to September on 2022, comparing it to those from 2018 to 2021. And you can see that there's a drastic increase, especially in regions 6 and 7, compared to 2018 to 2021 time period. This is looking at average drought level across the U.S. in the past year. And that measure is sort of the drought severity index, is an experimental method for converting drought levels from the U.S. Monitor map to a single value of a country. So again, the higher that number, the worse the number. And so again, the Northwest, Southwest, Northern Great Plains, and Southern Great Plains generally had the highest levels of drought. Again, 17 counties had this really, really high value. And then 2 of the counties happened to be in Texas. And looking at counties in both Oklahoma and New Mexico had ranked in the highest, in the high 50, top 50 drought in the past year. And then lastly, looking at sort of the national fire activity synopsis back in 2022, nationally, there were something like almost 69,000 wildfires reported in 2022 compared to 59,000 or so in 2021. And those consumed over 7.5 million acres nationally compared to 7.1 million acres. And what's happened that over time, these 10-year averages, there's been considerable variations in geographic areas. But what's happened is that in those areas that I've marked, Region 6 at least, it saw an increase in the number of fires when compared to their average fire statistics, and it's burned significantly more acreage during those times. What has also happened as well is something that is seen with the hotter temperatures as well, is that we've now seen the first cases of local malaria transmission in 2 decades. So at least in Texas and Florida, that this has already started to happen. So again, effects of climate change. Regional activity, so I'll talk about briefly Region 6 and then Region 7. First, I wanted to talk about some of the things that factors that impact the community's resilience and how communities respond. So thinking about in those living in particularly vulnerable to climate change, like communities living across, along coast or extreme weather. So those who are in Louisiana, for example, or coasts of Texas, those will be in those populations. Coping with higher levels of existing health risks when compared to other groups. So again, health disparities, health inequities. Living in low-income communities with limited access to healthcare or access to quality healthcare, again, access issues to even rural health areas as well. And again, limited English proficiency, as well as limited ability to be able to move during and before disasters as well. So all these factors are things that we take into account as far as regionally and thinking through working across with our partners. So back in 2021, we launched our Region 6 work group. We had Dr. John Balbus from OCHI to introduce and have a presentation launching our efforts And again, we've had quarterly meetings looking through and thinking about brainstorming these environmental scan and opportunities to address gaps, thinking through and working with our community partners, both state, tribal, local, and community-based organizations, looking at what are some of the community-driven interventions and promising practices for community engagements. FY23 Region 6 activities, two large topic areas. What we've had is one particular conversation that we've had in Beaumont, Port Arthur, Texas on June 9th. And this is one of a series of 15 nationwide conversations that have taken place in partnership with OCHI and ACF, Administration for Community for Children and Families. And these findings will help inform a nationwide Partners for Healthy, Climate Resilient, and Thriving Communities Summit, which will be from August 2nd to August 3rd. For August 2nd would be all folks, partners, federal and non-federal. And then for August 3rd would be federal staff only. Anyone who's interested in this, please see me. I can let me know. I will be happy to send you the links for this. And then on August 3rd, we'll lead some breakout sessions as well that will specifically have regional efforts related to efforts on August 3rd for federal staff. On June 13th, we had a meeting discussing with climate mayors issues that were cutting across regional leadership. So we had from HHS, we had CDC, SAMHSA, our Office of the Secretary, as well with regional leadership from HUD, EPA, and FEMA, thinking through talking about the climate mayors and what were some of the bigger things that are important for them. And these two topics were very strong messages that came across. Need for mental health prevention and treatment services in the affected communities, and then need for resources delivered directly to local jurisdictions and to small rural communities. In terms of Region 7, regional activities, Region 7 has had Tribal Climate Emergencies and Health Symposium July 11th and 12th. And this has been collaboration among, and it's co-hosted with EPA, FEMA, and a tribe in Nebraska. And it's requested by tribes after the symposium that they had back in September 2022. And they were going to be looking to follow up this efforts with scheduling routine meetings with tribal emergency managers, environmental directors, and health department folks. And next, as far as Region 7, again, Region 7 obviously has had and will participate as well in the summit that I was telling you about August 2nd and 3rd as well. But they are working with their federal executive board, Climate Change and Justice 40 work group, which is led by their EPA under Greater Kansas City Area Federal Executive Board. And the purpose is to better coordinate and facilitate climate-related resources to underserved communities. And then lastly, Heartland Environmental Justice Working Group. And then this is particularly led by the Department of Justice with members from 15 federal agencies and academia. And folks have any questions about these, of course, let me know and I can put you in touch with Captain Davids, the acting regional health administrator. So one of the things that I wanted to talk about again is how do we work better together with all of this? Many of you have seen these models, this model, social determinants of health, because that's sort of where we operate under in terms of how we do work. One of the things that we like to be moving forward is to put a lot of those efforts under practical unifying action under this ELTRR model, which is the equitable long-term recovery, resilience and recovery. And that basically does it in the well-being portfolio, and that carries the social determinants of health agenda into a practical unifying agenda. And what you can see is that what's been talked about here a lot is the middle of the circle that you can see is belonging and civic muscle. And that's basically, no matter how you look at everything, is that community engagement and community partnership is the center of everything that's being proposed. And what you can see is vital conditions. And the next slide I'll show is, this is basically how we are thinking about this whole model, is that belonging and civic muscle is that it's the center because it's both a vital condition and a practical capacity that is necessary for equitable success in every kind of work that we do. So when we think about health, there's reliable transportation, lifelong learning, meaningful work in health, humane housing, basic needs for health and safety, thriving natural world. And again, with that all said, I don't know if that's is that the next thing, is that the music is supposed to be playing afterwards? Okay, so this is getting towards the end. So this framework is a way to bring all of the federal partners together, and they have all contributed to this. And so this is a good way to unite and sort of bring all of the federal partners together to think through, and again, under the vital conditions framework. And quickly, the healthy, resilient communities are having these particular parameters, having the climate and natural disaster resources available, risk assessment for hazards in homes, having availability of understanding best for transportation and interpretation services, medication adherence and management of those before and during and after disasters, addressing mental and behavioral health care, as well as making sure the connectors are there. And then, of course, the trusted health and wellness resource for the entire household. And again, important part is strategic partnership, is connecting with stakeholders across the board. And that's why we're all here, is to make connections across the board. So I'll stop there. And again, thank you very much. And I'll pass it over to the next colleague. Thank you.
Hello, everyone. Can you hear me okay? Thanks. Wait for my slides to come up. There they are. I'm David Bells. I'm an environmental health officer for the Indian Health Service, and I'm here to give you a program overview of our Division of Environmental Health Services for the Indian Health Service in Oklahoma. And just discussion topics are going to be the program overview, our services that we provide and activities. And I'm going to have some slides of our field staff, so each of you will be able to see our field staff and have their contact information. And then some of our special projects that we have going on in the Oklahoma City area. So our mission with the Indian Health Service is to raise the physical, mental, social, spiritual health of American Indians and Alaska Natives to the highest level. And we have three distinct disciplines within the Division of Environmental Health. We have our general environmental health officers. These folks work in the communities doing general environmental health work, which includes like food safety, going in, doing inspections of food facilities, teaching food handler courses, doing mold inspections, lead inspections, any type of complaint we get where folks need assistance, air quality issues that come up. Our general environmental health staff work doing that. And that's usually where folks that start environmental health, that's usually one of their first positions within Indian Health Service is general environmental health. And then there's institutional environmental health. This area is focused on mainly our hospitals and clinics, but we also work some in the communities, doing ventilation assessments in our healthcare facilities. It was really important during COVID when we were trying to make sure our healthcare folks were safe from COVID, and then also trying to make sure that the air had circulated and was clear to be able to bring other patients into rooms after we had COVID patients in there. So we did a lot of assessments there when it came to ventilation. We also do radiation protection surveys in there, checking our X-ray equipment, make sure it's functioning properly, make sure that it's at the right settings to ensure that we're not overexposing our patients to radiation. And then we do safety, emergency management, assistance there for like accreditation purposes, and assisting the clinics with preparing for accreditation and the hospitals by doing mock surveys. So a lot of work there in institutional environmental health. And then at times we'll get called out in the community to assist with maybe an air quality issue that's going on where we have equipment that we can assist with identifying different chemicals that could be in the environment. For injury prevention, this is community-based injury prevention. And I don't know if everybody knows this, but injuries are one of the leading causes of death, particularly for groups 1 to 44 years of age amongst American Indians and Alaskan Natives. And so one of the things we do is community-based injury prevention to help prevent those injuries and deaths. The focus areas historically has been motor vehicle crashes and falls. But in recent decade, poisonings has become a major problem across the nation and also in Indian country. And so we've been doing work on preventing poisonings like with the opioid epidemic, and some of our special projects that I'll share at the end have to do with that. And we also do work in suicide injury prevention as well. So the Oklahoma City area covers Texas, Oklahoma, and Kansas. We have one tribe down in Texas, the Kickapoo tribe of Texas. And then we have 6 field offices located in Oklahoma and Kansas. The tribe in Texas is covered by the Lawton Service Unit. They provide those services to that tribe. In 2022, our user population was over 400,000. So we do have a very large user population, and the Oklahoma City area covers 43 tribes. And we provide direct services to 29 of those tribes. And we have 3 that we have buybacks where we provide specific services that's in an agreement with those tribes. So just to kind of go over our field staff and where they're located at. And so if any of our tribes have need assistance, they'll know who to contact. For our Lawton field office, they provide services to 7 direct service tribes. And the contacts down there are Todd Narcomi and Mike Cope. They both work out of the Lawton field office. And then out of Pawnee, we have James Isaacs. He provides services to 10 of our direct service tribes. And we do have 1 vacancy there. So if you know anybody interested in environmental health, please send them our way. It's a great opportunity to recruit from this podium. So I appreciate that if you'd share that information. But he's a district sanitarian, and he also helps supervise some of our staff. And he's been in that position for a while. And he's trained on, certified on lead, where he can do some work there that some of our other staff may not be certified on. So we definitely utilize him quite a bit for those type of activities. And then in our Okmulgee field office, we have Dustin Joplin. He provides services to 1 tribe, but it's also our largest tribe, the Muskogee Nation. And it's with Dustin, he actually went to he worked in Lawton to begin with, and then he went to the institutional environmental health program where he became trained to do institutional environmental health work. And then he came back to Oklahoma. So we have a huge asset there in Okmulgee by having somebody who's an environmental health officer, but also has some training in institutional environmental health. But he's also a district, so he provides supervision to a lot of our field staff. And then in Shawnee, we have Bo Carter, who provides services to 4 of our tribes there in the Shawnee Service Unit, and which isn't too far away from here. And then Clinton, service unit. It provides services to 2 tribes and 1 buyback agreement. And she's just started a couple months ago, so I don't have her photo up here, but it's Julian. And of course, there's her contact information for those that may need services out of the Clinton field office. And lastly, out of the Holton field office is Gabriel. And Gabriel provides services to the 3 tribes in Kansas, and then 1 buyback agreement. And then we have our area office, and Chris Cates is our institutional environmental health officer. And he provides institutional environmental health services to all of our tribes in the Oklahoma City area, and then also to our 3 urban clinics. And myself, I'm the institutional and injury prevention specialist for the Oklahoma City area. And so I'm in a hybrid position where I do both injury prevention and institutional environmental health work, which makes my day pretty interesting, because one day I'll be helping a tribe develop a elder fall program, or helping with installation of car seats. The next day I'll be in the hospital helping with ventilation, x-ray surveys, that kind of stuff. So it definitely makes the job very enjoyable. And then lastly, we got Danny Walters, who's our Director of Environmental Health Services. And he's got about 6 more months left in uniform, and then he'll be retiring. But we kind of think he might be coming back as a civilian too. So maybe he'll still get to see him around. But he's I think he's like 5 days from 6 months or something like that. So we're excited for him to be able to retire from the Corps. So some special projects I just wanted to mention. We started this project back in February at the Claremore Indian Hospital. This is a locking medication bottle. If you see the pictures here, the bottle, you can actually stick the pills in the bottle and put the cap on, and then turn the dials there, and it has a 4-digit code, or you can stick your pill bottle inside of it. And so at the hospital there, for patients that are on specific medications, we're utilizing this to try to help with the opioid epidemic. They're using it for patients that are on class 2 narcotics. I'm not a pharmacist, so don't know exactly which ones those are, but they tell me those are the ones that people like to steal. And so we're trying to help prevent some of these opioid poisoning, some of these addictions that are occurring. And there is a lot of data out there showing that's how a lot of teens get addicted to medications. They have a family member or someone that's on a class 2 medication, and for the first time they steal the medication, and it's easy to get to when it's in a regular pill bottle. But with a pill bottle that has a combination on there, we hope to keep them a little bit more secure. So we're test piloting this project. We bought 500 of these containers. We partnered with Johns Hopkins University. They actually helped fund it. And so more to come on this, but I wanted to share that. So if any tribe is looking at, things to do to try to help with this opioid epidemic, that you at least would be aware of this as a possible, opportunity to help. We're kind of pioneers when it comes to preventing poisonings with the opioid epidemic, with motor vehicle crashes, preventing those types of injuries. We know what works. We've got a lot of data, a lot of years of work trying to prevent motor vehicle crashes. But when it comes to poisonings, not as much, because there's still a lot of new stuff coming out. Now, I know with vehicles, there's a lot of engineering still occurring, but with poisonings, I think it's important that anytime we have some type of measure that we're putting in place to share that with others. So that's why I mentioned that in this presentation. And then we also have a project where we're handing out medication lock boxes to folks that are prescribed specific medications. So patients that receive over 50 MMEs of morphine, if they are prescribed naloxone, or if they're prescribed an opioid and a benzo at the same time, then we're giving them a medication lockbox, and we're teaching them how to use it. And we're also doing surveys to make sure that it's effective and see if we need to make any adjustments there. But that's one project that's going on, and this is at all of our IHS hospitals and clinics to try to help with this epidemic. And then we also have a Sharps pilot project going on at 5 of our facilities where we're handing out Sharps mailback containers and have a metal collection bin where they can dispose of their Sharps. These are for patients that have some type of injection, whether it be they have diabetes and they have to self-inject. That way they have a place to safely dispose of those Sharps. And we partnered with EPA Region 6 on this project. So there's great opportunities out there when it comes to implementing these types of projects with funding sources, and we appreciate those partnerships. And lastly, I wanted to mention that we're also working on standardizing our field staff on the FDA standardization, where when they go out and do surveys, they're all standardized on how they conduct those surveys. And we have a staff member that's been here 6 months to a year, Mike Cope. He's got a lot of background in food, and so he's taking that project on and making sure our staff are standardized. And we hope to have that complete by next year. And there's my contact information, and it's my understanding we're going to wait till the end for questions. Thanks.
How many of you are getting overwhelmed? It's a lot of information. Anyways, I'm Michelle Tennant, as they've already said. I'm with HUD, and you're probably wondering, why is HUD at the table with this? Well, because decent, safe, and affordable housing is generally the first place in which you protect your families. If you limit their exposure to risk, then you limit the potential for problems such as education deficits due to lead-based paint or something. So I'm going to run through a little bit about our programs, try to be very quick. First thing to say is most of our programs are tribally determined. So under self-determination, our tribes elect what programs they're going to do. So when I discuss that a program can do something, it's based on your tribe and what they submit as their activities, whether they do that. So we have two main programs that are funded, and one is the Indian Housing Block Grant. The other one is the Indian Community Development Block Grant. Under the Indian Housing Block Grant, or NAHASDA, that's your tribal housing program. So through the tribal housing program, tribes are able to address concerns with units that individuals live in that are privately owned or units that are owned by that tribe. So things such as lead-based paint, mold, radon problems. Those are items that they could elect to do an activity to assist in rehabilitating and correcting deficiencies or issues with homes that are owned by tribal members. Under the Indian Community Development Block Grant Program, another thing that's kind of neat is that we can build hospitals, we build health clinics, we build the facilities that assist in dealing with the issues that come up based on environmental health. Some of the new things that HUD is doing, they put out for consultation a radon policy, which is going to address how HUD does their NEPA reviews. And the radon policy is basically trying to address that when we're rehabbing a unit or we go to build a unit, that we need to be testing for the radon levels. And that's something that they're consulting. They've put a policy together. It's now out there for comment. I know tribes are very interested in this because it does have a cost impact on their programs. So feel free to go look at that. It is not final yet. So this is still your opportunity to be able to put comments in. We also have the Office of Healthy Homes, and the Office of Healthy Homes is where our lead-based paint, our lead hazard remediation, our Healthy Homes grants, and our mold grants are when we have those funded. So the neat thing about these programs is that this last couple of years, they haven't used all their money. So they are now looking at how they can incorporate tribes back into receiving funds for these programs. So they're going to be coming out with different consultation packages. So be watching. You know, we need to express the interest and the need for the money to go to the tribes in these areas to assist in mitigating those risks. Under the Indian Community Development Block Grant, we also have the Imminent Threat Program. We've had situations in the state of Oklahoma where we've had an entire water towers contaminated. And the tribes have been able to come to HUD and say, we've got an imminent threat. You know, this is something that wasn't related to us not doing our maintenance. It wasn't related to something that we could have prevented. They have to get independent verification of that imminent threat and that was something that was not related to a lack of maintenance. And that's a lot of times where we partner with Indian Health Services and they come out and they will provide the information that it was not related to a lack of maintenance or something that could have been prevented. So things like water waste treatment facilities, water towers, different things that affect a community as a whole, we can actually help fund with a set aside that comes through that program, help fund the mitigation of the issue. So ironically, we talked about climate change already. Several people have mentioned it. HUD is on that same role. Climate change is a big issue. I do work in the national office, but our Southern Plains office is actually Oklahoma, Kansas, Texas, Louisiana, Arkansas, and Missouri. So we're just a little different than the HUD region, but that's because we divided based on the number of tribes and trying to ensure that we were adequately serving the tribes within our region and that we weren't overburdening one region versus another. So I will say that there is a tribe in Texas that is not in our region, and that is the Isleta del Sur. And they are a Pueblo, so they're actually handled out of our Albuquerque office because it made more sense, of course, to keep all the Pueblos together. But with that being said, nationally, we have issues like in Alaska. We have an entire village having to be relocated due to the permafrost issue. So that's something that HUD is involved in. We also have in the state of Washington, we have a tribe that's having to move to higher ground due to the erosion of the coastline. They have flooding and, they're at risk of losing all their housing and everything. So we're assisting them in trying to figure out how to move housing to higher ground. And of course, with that comes cost. And, that's a bigger thing to navigate. So we've been trying to work with them. Now, ironically, I ran into Summer, who's in the audience today. And the other thing we have to do when we talk about decent, safe, and affordable housing, we in Oklahoma have the largest Superfund site at the Tar Creek Superfund site. How many of you are familiar with any of that? Okay. There's a few that are very familiar. At HUD, we had to figure out how we could ensure that the housing units that we are funding, or those that are going to be constructed, or the facilities that are going to be constructed are free from this situation. So it took many years and a lot of work to work with multiple agencies to come up with a process in which we could ensure that the houses that we're building today and the houses that we built in the past are not contaminated with lead, cadmium, zinc. And it took a long time, but we did finally this year, did it. Matter of fact, I'm leaving here to go present on it at the Intertribal Environmental Council. So but that's something that we work with, and it's important because we can't have our tribal children living in a house where they're playing in a ground that is contaminated, or living in a house that has lead-based paint. So with that being said, I do want to give homage to the outbreaks and the children. I have quadruplets, so if there was an outbreak at school, I was blamed for it all the time because they put the kids in different classes. So they'd all come home and then they take it all back. So we did the chicken pox for everybody, I think, in the school. But I appreciate your time, and I'd like to turn this over to Danielle O'Neill, who is with the Environmental Protection Agency.
Thank you so much. I really appreciate that overview of HUD's wonderful work in this area. Danielle is actually not going to be able to join us. She had to step out for a scheduling conflict. She does have some materials that we will include in that batch of supplemental materials for everyone. So with that, we're able to open it up to questions for our panel for the next few minutes before we break. So definitely line up at the microphone. All right, and I see some folks coming, so I'm going to sit down.
I have a quick question for poison control. I'm with ATSDR, the Agency for Toxic Substances and Disease Registry. When it comes to when you're calling with, say, your cell phone, or I know there could be other issues in some of our sovereign nations, what do you do? For example, like my personal cell phone is from Atlanta, but I live in Kansas City. So when I did have to call poison control for my own toddler who was eating laxatives, they had told me, oh, this is Georgia Poison Control Center. So how does that work in terms of making sure if somebody actually needs to get to medical resources, how do you direct that?
Can you? Okay, I'm working. So great question, and actually something that I didn't have a tremendous amount of time. It is important to recognize that. So right now, and this is where we need a lot of work, if I'm honest, and we're facing this on a national level, where ideally you're routed to the poison center that is closest to you, that's closest to the cell tower that you ping from. And we are being told, I'll just call them out. Well, we're being told by Verizon that that's not possible on a national level. And so it is an issue. So we, as a poison center, we all recognize that this is an issue. We are all trained very similarly across the nation in how we handle most all of our, let's say, non-toxic exposures, our home calls. So I would say well over 75% of the calls that we get. Now, if you're a healthcare provider calling from that capacity from a healthcare facility, what we will do is we will transfer you to your closest, your home poison center. So we want those patients that are being treated in a healthcare facility to be treated by their local poison centers. Now, if you call from Atlanta and you get the Oklahoma Poison Center with your laxative call, we're going to handle that every day of the week. We're going to even follow up with you and those types of things. But if we refer a patient to a healthcare facility and it's outside of Oklahoma, we basically transfer that case to that poison center. So we have our poison centers across the country. We have a pretty close-knit network in that I can probably tell you, names of people from a lot of poison centers. So we kind of work very closely together. And so we will just call that poison center and say, hey, we got this call. Here's the patient information. Here's the healthcare facility that they're going to. So it really should be pretty streamlined in how we all manage those. Does that answer your question?
Hello, Rosalinda Turk. I'm a citizen of Cherokee Nation, but I live in Washington State and I work for Washington State Department of Health as the Equity and Social Justice Manager for our Emergency Preparedness Division. I am curious. I come back to Oklahoma often for ceremony and to see my families. And I was curious, what is being done to address the air and water pollution that is being caused by the chicken houses? No, nothing? Huh? Okay. Guess I'll step over.
We're going to call the EPA on that one. This is CDC's convening, right? Power. That's a really good question because it does impact climate, right? And then for those of us who are fortunate enough to have air conditioning to cool off, that running that air conditioning also impacts climate because it pulls on the grid, creates more carbon footprint, and etc. I have a whole notebook of questions because what an awesome panel. Round of applause for the panel. Yay. Yay, you. And you. So it's great that we're in Oklahoma where the majority of tribal citizens may have access to a cell phone. But we have rural areas in Oklahoma, and outside of Oklahoma, we have rural, remote, and frontier. And I know that we're only talking about the region here in particular, but it's a thought point. We call the poison control. How do we call? Does somebody have a cell phone to call? I know that when I was working on the COVID response and our initial was wash your hands with soap and water. Well, that's not going to work in a lot of places in Indian country because we did not have water. And as you mentioned, then we're burning alcohol, which then impacts, my own little tiny bit of alcohol in my hand sanitizer, but all of us in this room, it starts to add up, right? So thank you for pointing that out. IHS, coming to you first, sir. Yes, pass that mic right on down. So the environmental reviews, the outcomes, how is that data accessible? I know that we had CDC employees deployed to IHS area offices to help because it was a huge workload. And you also have a huge number of vacancies across IHS. But how is the outcome of those data, of those environmental assessments accessible? Because that will help us. I mean, we really at some point have to get to the whole of government and sharing information, because what you know may impact what CDC needs to know as we all move forward. So you, sir, may not have that answer of how do we access the outcomes of your environmental assessments?
Yes, well, it kind of depends on what type of assessment you're talking about. Like,
I
for-
love it. It depends is
Yeah,
always the key word. Yeah.
Yes, but that's a good question. I know for like our assessments for when we're like checking our facilities, like our food facilities and stuff, we share those with the tribes, and then of course we provide it to the facility itself. So those would be available upon request, and I'd have to check with our PIO to see what the process there for that request, if we received a request for that. But if a tribe requested information like tribal council and stuff, we could definitely share that. And a lot of times we'll provide them a copy of the report anyways. So they do have access to a lot of the reports. So kind of depends on what the report is though.
Sure. And therein lies, I think, one of our greater challenges because of all the things about the rules and regulations and who have access. And if you are requested where a tribe is partially compacted, a 638, but left the environmental health component at IHS, you have a responsibility, but who still gets to access that? But I think that is a great example, which leads me to one other question for you regarding your food handling. And you all do such wonderful trainings, right? And the certifications, and those are utilized in the childcare and Head Start programs, the elder programs, the elder food program. How do you help us learn how to handle safely our subsistence hunting?
Can you, I guess more
Deer
descriptive-
hunting,
Oh.
fishing, et cetera. So how are we ensuring that we are properly dressing, cleaning, and hanging, and quartering, and et cetera? So do you, in the environmental health lane, right? Because we all have our lanes that we work in, help with, as many of us are reaching back and grabbing our traditional and cultural ways, we may not know. We may, given so many of us are urban or, right off the reservation, and we may not know. How do we help them?
That's an excellent question. We actually ran into this about 3 months ago, where a tribe wanted to have a ceremony, and they were butchering a buffalo, I believe. And it's all case by case basis. They contacted us for assistance, and we all put our heads together and provided them, technical assistance with doing that in the safest way possible based upon our knowledge of food safety. And so it was kind of, I would say, case by case to be able to assist with that. And it's up on request, because we don't insert ourselves where we're not asked when it comes to the ceremonial practices, whether it be a powwow or any type of event. We usually get asked to come and help to ensure that the food is safe when served to the public.
Yes, thank you. And thank you for honoring the boundaries around our traditional and custom events and so forth. However, food handling is food handling. And I think that perhaps a FAQ on the website, right? Because yes, it's going to be case by case, but there are still standard this is what you do for a deer. This is what you do for a buffalo. And here's a salmon and here's a trout and here's, and food poisoning, or from particularly my personal experience from fish. Oh boy, you don't get over that one quick. But just a suggestion for consideration. Now, since you said something about this, which is really injury prevention. And like you, we all get to wear so many darn hats, and it keeps our day moving, right? And excited because I'm not doing the same thing over and over and over. But with injury prevention, about the vehicles, right? And you're putting car seats in, but not a whole heck of a lot of individual tribal people can afford those new cars. Had an oil change on my old truck, and I decided to go to the dealership. I had a coupon. But I started looking at the price tags on those with all the safety features, the airbags, the what do they call them? Lane change mirrors that warn you somebody's there, and auto stop if you get too close, and rear end, and etc. But we can't afford those things in Indian country. And I know that we started all this back with the Senator Stevens bill, in looking at fatalities on highways and Department of Transportation data. What would you say if we don't have all of the whistles and bells of the airbags and all of that? Do you still see us not wearing seatbelts? Do you still see us hauling our family in open beds of our pickup trucks? What's your experience, sir?
Well, the rate of car seat usage and seatbelt usage is lower in Indian country. However, we do have programs to try to increase that, and we have seen increases in some communities where we've implemented those programs. They had a program IHS had for years, the Ride Safe, Sleep Safe program. And we still do that when we have funding available. It's not called Ride Safe anymore, but here in Oklahoma, a couple right before COVID, we had a program where we were offering the Head Starts and childcare facilities to be able to provide car seats to their to the kids at their centers there, and then we had car seat technicians install them. And I will say, when it comes to car seats, as long as the car seat is installed correctly, that necessarily the price tag isn't necessarily important. If you look at the data there, when you have a seat that's low cost installed compared to a high cost, if it's installed correctly, the result's the same as far as protecting of the child and reducing the amount of injuries there. So, but I hear you on the affording the bells and whistles on the new cars. My car messed up on me last year, and I had to buy a car. And tell you what, they got a lot of different features compared to when I bought the previous vehicle. And yeah, it is nice to see some of that technology there, and hopefully over time, everybody will have better technology that'll help continue to reduce those injuries.
Thank you for that. Over to HUD, our friend at HUD. Thank you. Thank you so much. So, it's always so frustrating when funds are still left over, right? They're not spent. And okay, now how can we get them out to Indian country? Which is a boggle to me of, why don't we figure these things out first, right? But here nor there, or here. So when you're talking about, the mitigation issues and how, you're talking about lead paint and radon and et cetera. So I'm wondering, can HUD help with cleanup of houses that were used as meth labs? Not where a house that somebody was smoking meth in, but cooking, making, right? Meth labs in the house.
And thank you for that question, because that is a big issue in Oklahoma. We see it a lot, but we're seeing it all over the US. I will say that there are situations where HUD could assist in cleaning up that property. The big thing is what the future of that property is. So like if a tribe was to choose or elect to maybe go in and mitigate and then clean it up, turn it around, put it into their housing stock, that would be an option. I do know that tribes also analytically think about that because the amount of dollars that go into that housing unit when you go in to do remediation makes the cost extremely high. So, so there is some, thought process that the tribes go through in that, but that is something that would be eligible. The big thing would be that unit would have to be turned around under our housing dollars. It'd have to be turned around and made available to low-income Native American families in the area.
Yeah, thank you. Thank you for that, because pretty much if a tribe has housing stock, it's going back into their citizens. Hopi is a perfect example. They're landlocked. They have to do something with the same amount of houses. A lot of our reservations, same situation. We don't have the luxury to just demolish a house and decide that we're going to build a different house somewhere else or leave it abandoned, right? Because then that becomes a whole nother problem for the climate. These are really teaser questions for those listening, and hopefully some of you will come behind me in the microphone line here. Access to data. So one of the things that we talked about was, you talked about it too, is the density of people that live in a single family house, right? It's not uncommon that in a maybe where we have a few 3-bedroom homes, but we'll have 10, 12 people in that house. So is there a formula that HUD actually utilizes that per individual living in the home, you need X number of square feet? I mean, for federal workers, we have the formula of, for me, I get this amount of square feet. I would think that there would be some sort of formula like that.
So the answer is yes and no. And I know you hate those answers, but when we get to the tribal side, it's a little different. So on the public housing side, yes, there is some rules and guidelines as far as bedrooms, number of bedrooms, square footage, and population. When you get to the tribal side, that's based on self-determination and the tribal housing putting policies together, and their policies addressing that, or tribal ordinances addressing it. And that is the uniqueness of Indian country, as we all know. And we also know that we have generational living, and some of that is cultural, some of that is by need. I will say that in our office, we always try to educate everyone that we speak to, whether it's the appropriators or if we're talking to the new incoming political appointees. In Indian country, it's not homelessness, it's houselessness. It's the lack of housing, because the family members will usually take the individuals that are homeless in. And so therefore they are what we call near homeless. We did get some wins recently. So with the Tribal HUD VASH program, which is for veteran assisted housing with supportive services, through that program, we actually were able to make our rules address near homelessness. So you have that individual who may be couch surfing, or the individual who has a place to stay, but it's not their home to stay in. We were able to address that with that. Now, like I said, with the other programs, it is about self-determination and about the tribes determining what their rules are. But I also see that I'm not going to let my family member, sleep in their car. I'm going to tell them to come to my house.
I appreciate that. And of course, it's all about sovereignty, and we provide as much technical assistance as requested, right? So the tribe has to request the technical assistance. Thank you kindly. I see someone else behind me, and I also see Donata is going to try and wrap us up. Thank you all so very much. And I do have other questions in case we have extra time. Thank you.
Okay. Hi, we have a question from a virtual attendee. They want to know, does HUD help with tribal families that are displaced by wildfires?
Okay, so there are yes in two different ways. Okay, so when you're displaced by the wildfires, you can go to your local disaster area, and they will assist you in looking at the public housing side and to see if there's any units available. Generally, what HUD does when there's a disaster, we start looking at any units that we have available that are like a HUD home, or if there's a housing entity that has units that are vacant, and we start trying to assist with finding those homes to place people. Now, on the tribal side, that would be, once again, that is based on the tribe's determination on how they want to utilize their program money. So if the tribe was to elect that they would have a set aside of money or a line item in their budget that they were going to assist individuals that were displaced by natural disasters, that would be something that would be eligible. The tribes have service areas, but under our program, they're able to define that they want to provide services outside that area. Most tribes elect to only provide within their service area or their reservation. And I'm sorry, I keep saying service area, 26 years, it's a bad word to say within their reservation. But that's their choice. But a lot of people have so much need in the reservation and on the reservation that they don't sometimes go outside the reservation because the need cannot even be met where they're located.
Thank you.
Want to give a big thank you to our panel and all of the valuable information that was shared with us today. So let's give them a huge thank you. It is not over yet. We are going to transition to a networking session where you'll be able to speak with the panel members one-on-one, ask any questions that you may not have asked during the panel session. Also, I want to introduce our CDC colleagues who are here in case you would like to speak with us as well. Again, I'm Donata Green, and I'm going to ask them to stand as I introduce them. Audrey Dowling is with us as well, who works in the same office that I'm in, the Office of Policy Planning and Partnerships. You heard from Sharonda Buchanan earlier, who's in the Office of Priority Projects, Innovation and Environmental Justice. I may have gotten that acronym wrong. Also, we have Corey Coco, who is with Region 7. So she is here who may be able to answer some questions related to Region 7 and environmental health. We have Patrick Young, who is Region 6. And so all of these individuals helped us put together the summit that we have today. We also have a few of our other presenters, which you'll hear from, I'm sorry, somebody was saying hear from later today and tomorrow. So if you want to stand up here as well. Yep, Terrence. And so they will be talking about resources in terms of grants and other cooperative agreements or other things of that nature. We have Ayanna Perkins, who is in the Division of Environmental Health and Science Practice. And so Ayanna deals a lot with health equity and other environmental justice issues. We have Paul Schramm, who is our climate expert. And trying to see who am I missing? Rio. Can't forget about Rio. Rio is in Sharonda's office, OPPIEJ. So she'll be able to answer some questions as well. So the networking session is very informal. So feel free to walk around. Oh, Rachel Rogers, our PFAS expert here. Troy Ritter. I needed a list. Troy Ritter is our water expert and Jane Lee Brownfields. Did I get everyone? Summer King. Next time I will come with my list, I promise. So again, it's very informal. So if you would like to network, please feel free. If you'd like to go to lunch, lunch is on your own. And so we've asked NIHB to put together a list of options. So if we have a list of lunch options that are walking distance, and there may be some food trucks out there as well. So, okay, time-wise. Yes, and we do have the overflow room next door you can use as well. So Brett, what are we looking at time-wise? Hour and 15 minutes? Okay, so that is what? I'm still on Atlanta time here. So 1:30 Central Time, we can meet back in here.